Hello. Thank you for having me over. It's a great pleasure to be here today. I'm Todd Park. I'm the Chief Technology Officer of the U.S. Department of Health and Human Services. For those of you who don't know who HHS is a federal department that's a principal agency in charge of advancing the health of the American people. And it comprises Medicare, a huge insurance program for the elderly, Medicaid, the insurance program for the indigent, the National Institutes of Health, the Food and Drug Administration, the Centers for Disease Control and Prevention, and about 20 other subdivisions, all of which are part of HHS. And the CTO job is a new job they created about a year and a half ago. I have actually absolutely no government experience whatsoever prior to being CTO of HHS. I was an entrepreneur. And that's my background. And when they first called me, I said, "Why are you calling me? Because I don't know anything about government." And they said, "Exactly." They explained to me that the CTO job is actually not the dude who runs all technology at HHS, but is a position they've created to be an internal entrepreneur in residence, a change agent whose job it is to help HHS harness the power of data and technology in innovative ways to improve the health of the American people. And so I convinced my wife to move to DC to do my tour of duty, serving my country. And I have to tell you, it's been the most entrepreneurial experience I've ever had. It's been absolutely extraordinary. It's an extraordinary time to be in health and healthcare in general, especially if you're interested in how data and technology can help improve it. So I want to talk today about what I really believe is a historic opportunity. I really believe there's never been a better time in American history to be an innovator at the intersection of information, technology, and healthcare. And the fundamental reason why is that there are two big megatrends that are locking in that are absolutely massive in their implications for innovation in healthcare. The first is new incentives to actually focus on the improvement of quality and health. And the second is what I call information liberación. And what I'd like to talk about today is these two trends in more detail because they collectively comprise rocket fuel for innovation in healthcare. The first piece, new incentives, I want to break down to two parts. So how many of you actually have any familiarity with healthcare or health issues? All right. So do you all know what meaningful use is all about? OK. So for those of you who don't, meaningful use is a new program that was part of the Recovery Act where Medicare and Medicaid are paying bonuses of $44,000 to $60,000 per physician or $2 million plus per hospital if you adopt and meaningfully use electronic health records. This is a really, really big deal because electronic health records, as I think everyone here knows, have been adopted by American doctors and hospitals at much lower rates than lots of other countries, and that has big implications for efficiency and quality. And so this is actually leading to a growing tide of physicians and hospitals moving to adopt health IT. But one critically important point about meaningful use is that as opposed to just reimbursing people for the purchase of electronic health records, Medicare and Medicaid are actually saying, no, that's not enough. You have to demonstrate meaningful use of electronic health records to improve care. And there's been a standard defined for 2011 that's really about capturing meaningful data and sharing it with other people. 2013, it's about advancement of clinical process control and improvement. And in 2015, it's about improved actual outcomes. But the point is that we're paying for results. We're not paying just for the adoption of technology. And this is critically important because I think, as this room knows probably better than anybody, blind adoption of technology doesn't actually advance the ball on anything, right? It basically takes a broken process and makes it a highly automated broken process at great expense. So what you really need to do is you need to actually change the processes. And so what meaningful use does is it actually sends a signal that we expect technology to be applied as part of improved clinical processes to deliver better outcomes. And that's very, very important, not just for docs and hospitals, but it's very important for the health IT industry. Because historically, electronic health records were essentially glorified billing systems. Okay? They documented care for the purposes of sending a bill to an insurance company or defending against a malpractice lawsuit. They actually didn't do very much, to be perfectly honest with you, to improve actual health and healthcare. And this meaningful use standard sends a signal to the vendors in the industry that they actually have to begin to morph their capabilities to actually improve health and healthcare. But the big, big, big deal when it comes to new incentives is actually the Affordable Care Act. Meaningful use bonuses are just the appetizer. The really big game-changing event is the Affordable Care Act. And just as background on this, how many of you know how we pay for health care today in America? Yes, you. Yes. Yeah.
First and foremost, whether you have private insurance, whether you're over the age.
Oh, yes, I'm sorry. So yes, but in terms of how doctors and hospitals get paid, how do doctors and hospitals get paid?
Well, there's CPT codes and ICD-9 codes.
Yes.
Every procedure, which is a CPT code.
Yes.
Every procedure that any medical provider, be it a doctor or a practitioner or physician's assistant,
Yes.
that they provide,
Yes.
there is a value. It's
Yes.
usually the federal government gives a value for Medicare purposes, and then private insurance companies, for example, Blue Cross Blue Shield or Aetna,
Right.
will sort of track
Right.
based on what the federal government is paying through Medicare.
Yes.
And then physicians and hospitals, providers, generally providers, have individual contracts with each private healthcare company. For example, they'll say Blue Cross,
Yes.
for every physical exam you do, we'll pay you $57.
Right.
But it might be $53 under Medicare, it might be $58 under Aetna.
Yes.
It's all contractual.
Yes. Yes. So, so she knows what she's talking about. So, and the thing I really want you to take away from, what was your name again?
Jessica?
Jessica. The thing I really want you to take away from what Jessica said is that it's per procedure, right? For a medical office visit, you get $57. For a surgery, you get $2,000. For a hospital stay, you get $5,000, right? Go ahead, Jessica.
And the very important thing, which people are having problems with, if you don't have insurance, you generally pay a much higher rate.
Well, that's also right. That's also right.
So if you're uninsured,
You actually are the only people that pay full charges, which is
if you're,
ridiculous,
for
right?
example, unemployed and don't have insurance and you're
Right.
having no income, you actually have to pay more for healthcare than somebody who is
That's right.
insured or probably has a job.
That's right. And the Affordable Care Act, of course, through the provisions that have been, I think, most well publicized, does actually address this problem of the uninsured in a dramatic way. But there's another section of the Affordable Care Act that hasn't been talked about at all, which is talking about how Medicare actually pays docs and hospitals. Because the interesting thing that Jessica did not say was, if people take better care of Jessica, they get paid more. If people actually get the care that's the stitch in time that saves nine, so they don't go to the ER, they get paid more. She didn't say that, because in fact, those things aren't true. If you actually deliver better outcomes, you do not get paid more. If you take better care of someone, keep them out of the hospital, you do not get paid more. But if you do more surgeries, you get paid more. If you admit more people to the hospital, you get paid more. So what does the healthcare industry do? What do providers do? They do what society pays them to do, which is deliver more and more visits, surgical procedures, and hospital visits, right? So far from our system being dysfunctional, it's delivering perfectly what society is paying for it to do, which is rapidly escalating volumes of healthcare services, right, at $57 a surgery or a visit, right, without commensurate leaps in quality and health. So at the end of the day, if you really are serious about transforming the healthcare system to produce better quality, to produce better health, you have to pay it to do it. That's the way the market works. And in a series of provisions in the Affordable Care Act that are very important, but actually not as well known, Medicare is authorized, empowered, funded, and directed to change how it pays for care from pure fee-for-service, right, payment per visit, per surgery, per hospital, to pay for quality and health. This is a massive and fundamental and long overdue transformation in how the biggest payer for healthcare services in America pays for care. All the private insurers, interestingly, are saying, hallelujah. They've wanted to do the same thing for a very long time, but they can't because Medicare, as the biggest payer, has been paying fee-for-service. And doctors can't split their brain between, okay, I'm going to actually optimize half of my practice for fee-for-service reimbursement and half of my practice for proactive population health management, right? Those are two completely different setups, and they can't do it. So the private insurers have actually been inhibited from implementing payment reform because Medicare hasn't done it, right? But now that Medicare is doing it, all the private insurers are saying, we're going to do it too, because it makes logical sense. If we want better health and better quality, we should pay for that and be able to fund providers to make the investments and do the actions to actually do that. So the Affordable Care Act is driving a shift from pay for volume of service to pay for value. If there's nothing else that you take away from today's talk in terms of change incentives, take that away, because that is a historic shift with massive implications for innovation in healthcare. There are a bunch of programs, if you're interested in talking more about it, I can talk about more about it afterwards, but there are a bunch of different programs in the Affordable Care Act that embody this. Have you heard about accountable care organizations? A reg was just published, regulation just published, announcing the creation of accountable care organizations as a new program that will launch January 1st, 2012, essentially where physician groups and hospital systems can sign up to be accountable care organizations to take responsibility for the health of a population of Medicare beneficiaries and be rewarded for actually improving quality and health in that population, which is a big deal. Other programs, patient-centered medical homes, bundled case rates, I won't bore you with all the technical detail, but there's a lot in there. And actually beyond that, there's a new center called the Centers for Medicare and Medicaid Innovation Center, which I think is the coolest place to work in the federal government right now. It's this new center at Medicare and Medicaid that has been empowered to identify, test, validate, and scale new ways of paying for and delivering care that improve quality and lower costs for Medicare. It's been given $10 billion to fund this research. But even more importantly, it's been given a magic power, which is that basically if it identifies a new way of paying for care, delivering care, that delivers better results for the Medicare population, it has to submit that to the CMS actuary, the Centers for Medicare and Medicaid Services actuary, who basically does a scientific assessment of it. And if the actuary says, thumbs up, this is cool, then the secretary is allowed to implement that without having to go back to Congress or consulting with anybody else. Basically, they take it through the so-called rulemaking process, there's public comment, et cetera, right? But this is a very direct path for payment reform to become national policy for Medicare and Medicaid. So that's a very direct and wonderful way and data-based and empirical way for payment reform to happen. But this is a really, really big deal. So I don't want to bore you with the details, but this is a fundamentally important shift that creates a lot of opportunity for innovation. Why? Because if you think about how care delivery works today in a fee-for-service reimbursement environment versus how care delivery needs to work in a world where you're actually trying to optimize health and quality, right? Care delivery looks very different. So right now, your average primary care physician office is like a restaurant, okay? It's a table turn business. Turn as many tables as you can. Bring as many people through as you can. If you're wondering why the time you spent with your doctor has gone from 10 minutes to 8 minutes to 6 minutes to 3 minutes to now I don't even see the doctor. I say hello to like a nurse, get my blood drawn. Doctor says hello when I leave. It's actually because that's what they're actually trying to do. They're trying to see as many people as possible, right? Are they actually proactively monitoring the health of their patients? Are they proactively making sure that you're following up on the abnormal lab result? Are they actually making sure you're getting screened for all the stuff that you need to? Are they taking the time to counsel you about how to actually quit smoking? No. Why? Because they literally can't afford to do it. They cannot afford to do it because actually they're not paid to do it. In fact, if they tried to do it, they'd go bankrupt in a flash. But in the world of the future, they're going to have to do that. These different organizations, in order to actually make the most money under these new reimbursement schemes, are going to actually have to track the health of their patients. They're going to have to know who actually hasn't gotten the right care. They're going to have to know what's happening to this patient in lots of other medical offices that are also caring for this patient. They're going to have to actually coordinate with those offices. They're going to have to actually identify gaps in care to fill with the right care. They're going to have to do a lot of proactive stitch in time saves 9 to help this asthmatic diabetic with congestive heart failure not have an event that will lead them to hit the ER, which is terrible for the patient and actually escalates costs dramatically, right? And that's a set of muscles that doctors and hospitals just don't have right now. They don't have right now because they've never been paid to build those kinds of muscles. And in order to actually do that kind of proactive population health management, proactive patient health management, care coordination, stitch in time saves 9, they're going to need to do advanced data mining and analytics. They're going to need to actually integrate information about that patient's care across lots and lots of different care providers. They're going to need to actually timely information and decision support about what to do in a given situation. They're going to need to extend the reach of the physician outside the physician's office into people's homes and other settings. They're going to need to engage consumers to help them actually stay compliant with their medications, et cetera. In short, they have to do a whole bunch of things they don't know how to do. And while some people are actually scared by this gap, I'm really excited by this gap because this is the world's greatest current entrepreneurial opportunity, right? When a $2.7 trillion industry shifts the entire basis on which it's paid and needs this to do it, that is the greatest entrepreneurial opportunity since the internet, and one that will create incredible social value. So I'm actually here today not because I like to hear myself talk, but because one of you is going to create the Facebook, Zynga, Google of health and healthcare. You'll build into a company. It'll help a lot of doctors, hospitals, and patients. It will change American healthcare. It will fund your kids' education and their kids' education. You'll create jobs of the future. And you'll be one of the most important healthcare figures of the 21st century because you haven't gotten the memo about what's impossible. And you'll invent the thing that makes improvement in healthcare possible. I don't know who it's going to be in this room, but I think that one of you is going to be that person. And I hope you seize this opportunity and actually do something because your country needs for you to do it. and this is actually one fundamental truth I want to actually explain about how HHS is thinking right now. HHS ain't going to transform healthcare. We can't. What we are seeking to do is to help create the conditions that unlock market forces and private sector innovation to change healthcare. You're going to change healthcare, not me. My job is to help create conditions that enable you to do it. So that's why I'm here. So we're trying to say, look, this is an incredible opportunity. Please do something about it. Please actually save healthcare as we know it and create a lot of economic value to boot. So even more reasons why this is such an incredible opportunity. So that's incentive change. Any questions about incentive change? Was that reasonably clear and coherent? Okay. So information liberación. 3 parts. The first is a rising tide of data liquidity, patient data liquidity, right? So patient data in the past has not exactly been liquid, unless you define pieces of paper sitting in a manila folder written in inscrutable script as liquid. That's not liquid. That's like anti-liquid. That's like a solid. That's like incredibly heavy lead-like solid, right? So, and if you think about what the primary care practice of the future has to do, understand everything about your health, who's done it to you and when they did it, and what someone should have done and didn't, right? Are they going to magically like look into these lead solids and aggregate the picture of your health? No, of course not, right? So a fundamental prerequisite of understanding what the heck is happening to you and making sure you get the right care is that we need information about, that your doc needs information about your care, right? So exciting things happening on this front. So first of all, that meaningful use program I was talking about, this mass adoption of health IT with meaningful use bonuses, it's turning the manila folders into electrons, into electronic health records. One criterion for you to get, if you're a doc or a hospital, your meaningful use bonus is you have to be able to exchange that information with other people. So you can't just say, I've adopted you electronic health record, but it's all locked away and it won't share with anybody, right? Give me my bonus. Medicare will say, no, not so much. Actually, you have to demonstrate the ability to exchange with other people, A. B, there's very cool work happening to make it super easy to make that exchange happen. So there's a project that's called the Direct Project, NHIN Direct Project, Nationwide Health Information Network Direct Project. Have you heard about this? There's actually a really cool Gov 2.0 story. So what happened is there was a doctor who came to a public hearing. And he said, look, I understand that y'all are doing a lot of very complicated, exciting work about health information exchange, but I've got this problem. I've got this patient, and I've got this patient's record. I need to send the patient to a cardiologist. Can I just send the record to the cardiologist? And he actually reported to this esteemed health informatics board that he had emailed the patient's record to the cardiologist. At which point the board had a heart attack because he said, oh, it's a massive privacy violation. You broke like 18 laws. Oh my God, And the doc said, look, I understand that was bad, all right? But look, before you do all the really fancy, uber complicated stuff, can you just help me securely and simply send a patient record from me to a cardiologist? And so he said, that's a really good suggestion. And what we did was instead of hiring a bunch of government eggheads to think about in a room really intensively, we posed it to the public. We said, this doc has a problem, like lots of other docs. We need someone to solve the following problem, a challenge, right? How do you get a package of clinical information securely from point A to point B, whether it be a lab result, a prescription, a care record, without violating 18 laws, without endangering the patient's privacy, and in a way that's so simple, right, that your teenager could program it. Because it probably has to be that simple for it to scale. And we created a wiki space and a kind of neutral public forum that anyone could join to help solve the problem. So 60 different companies who were blood enemies of each other, electronic health record companies, Microsoft, Google, et cetera, joined forces and in 90 days created a spec. And the reason why they collaborated to do this was actually they were each calculating that for meaningful use to work, right, and for their clients to get the bonuses, they would either have to collaborate or they'd have to build one-to-one interfaces with each other and their customized installations at each health system, which would be incredibly expensive and take forever. So they decided collaboration was better, particularly if the government was actually acting as the neutral arbiter. So they came together, less than 90 days created a spec for secure healthcare email. 9 days after that, put it into production. The first production transactions happened. And now 68 companies representing 90% of the electronic health record market in America have agreed to implement this by the end of the year. And this has basically happened in less than a year, which is pretty amazing. So it's another example of the government sort of not being the problem solver, but just expressing on behalf of society a problem, which then the private sector came together in record time with incredibly low expense to solve. So this is actually a really big deal. But a real consequence of this is that information is now going to be flowing in a much more liquid way than before. Have you heard of Blue Button? If you have, I'd be shocked. It's kind of a geeky thing to know about. But Blue Button is another initiative that exemplifies this rising tide of patient data liquidity. So it turns out that the Veterans Administration, right, which cares for vets through a whole bunch of hospitals and doctors' offices, and Medicare, right, the insurer for the elderly in America, are two of the largest stores of personal health information in the world. Medicare has records of all the claims it's paid on your behalf. So it actually has a record of the services that have been delivered to you, right? VA has, the Veterans Administration has electronic health record information about veterans, right? So all Blue Button is, it's essentially a new capability we've deployed that allows a veteran or a Medicare beneficiary, about 55 million people, to get a copy of their own information, to download a copy of their own information. This turns out to be a revolutionary thing, because in the private sector, people have not historically allowed you to do that. And people don't know why. One interesting comment that we got after we deployed this capability to allow a Medicare person to get their own claims or a VA person to get their own personal health record is people asked us literally, like hospital systems would say, were you allowed to do that? Like, isn't it illegal to do that? And we said, dude, if it were illegal, we probably wouldn't have done it. But one interesting signal is that, since we've done it, we pretty clearly communicate it's not a violation of federal law to do it. And so more and more people are actually now starting to do this, which is very exciting. But that then allows anybody who's a vet or a Medicare beneficiary or others who have gotten Blue Button data to take a copy of their own data, upload it into a personal health record, upload it into an application that helps them manage their own health. Because actually our attitude is it's not our data, it's your data. It's the veteran's data. It's the Medicare beneficiary's data. We just happen to be the custodian of it, right? And so you should be able to have a copy of it if you want. But that turns out to be, strangely, like a new deal in healthcare or something. So we're trying to change that. But this is very, very fertile ground, right, on which to build new applications that help providers and patients manage health, right, under these new incentives that reward providers for effectively managing health. So it's a very, very important and complementary trend. Another a piece of data liberation is market transparency. What characterizes a market? What's the simple definition of a market? Okay. And how important is it for buyers and sellers to understand price and performance in a market? What if you don't know price? If you don't know performance? Can markets function? I would submit to you that for an efficient market to work, you need to know price and performance. And if you don't have a market. So by that definition, healthcare has absolutely not been a market, because price and performance has been really opaque. So one of the things the Affordable Care Act does, the health reform law does, is it actually brings a lot more transparency to the healthcare market. So for example, we launched a site in July of last year. That's the first site, healthcare.gov, where you can see a comprehensive inventory of all public insurance programs and private insurance plans across the country, how much they cost based on your smoking status, birth date, zip code, family size, what the benefits are, the rate at which they actually deny people for care, and see it all in one place for the first time. Actually, even more importantly than that, and this telegraphs what I'm about to say next, we're planning not just for this data to actually continue to be on our healthcare.gov site, but we're planning to liberate it through downloadable files and through APIs to allow anyone else to extract that data and actually build a better website than us. Because we think it's ludicrous that the government should be the only operator of the first comprehensive healthcare Expedia for health insurance. It's just silly, right? We're more than happy to have our own reference implementation of the data, so we eat our own dog food and check the data out, right? But if this really works, 98% of the use of the data in healthcare.gov will not be on healthcare.gov. It'll be through a whole bunch of other sites and applications that actually help present the data. Also, the Affordable Care Act compels us to collect and publish a bunch of new information about hospital quality, about physician quality, et cetera, because that's really not widely available either. And again, that's very important to help empower consumers and help advance the ball on quality. Which leads me to my final point, which is that the third piece of information liberation, and the final reason why it's such a phenomenal time to be an innovator in healthcare, is that HHS has launched something called the Health Data Initiative. And the point of the Health Data Initiative is to turn us into the NOAA of health data. So do y'all know what NOAA is? I didn't, actually, until a year and a half ago when I joined the federal government. But NOAA is this agency that, it turns out, collects virtually all weather data in the United States. So it's not like your local newscaster measures barometric pressure himself every morning, right? He actually gets it from NOAA. And NOAA chooses to do something very interesting with this data. It publishes it online in machine-readable form, downloadable by anybody for free without intellectual property constraint. And then that data feeds all kinds of innovations like the Weather Channel, weather.com, iPhone weather apps, weather insurance, weather research. It's a wonderful example of a whole ecosystem of private sector innovation built on top of public sector data. So we said, that's really awesome. Why can't we do that? So we have been, through this Health Data Initiative, publishing data from HHS's vaults that taxpayers have already paid for in an effort to seed private sector innovation using the data. And we did an initial experiment where we took a few data sets and made them public and really easy to find and use around community health data, like smoking rates, obesity rates, access to healthy food by county, and hospital quality, nursing home quality. And we challenged a group of about 45 innovators to do cool stuff with it. And less than 45 days later, in a big public meeting hosted by HHS Secretary Kathleen Sebelius, June 2nd, these innovators showcased over 20 new or upgraded applications that they had built using our data. I just want to talk about a few of them. So Bing, one of the godfathers of the whole Health Data Initiative is a guy named Tim O'Reilly. Do you know who Tim O'Reilly is? Okay, so this is one of the few audiences I talk to, because I talk to mostly healthcare audiences, and they say, who's Tim O'Reilly? I think Thomas Jefferson of the web. And y'all know who he is. So one of his fundamental laws is if you want data to change people's lives, don't make people find the data. Make data find people where they're already making decisions where they could be helpful, right? So Bing took this to heart, and they took a really cool data set that we have called Hospital Compare, which has patient satisfaction and hospital quality performance for hospitals across the country, and which we make people find using a website called hospitalcompare.gov that nobody knows about, no one uses, right? So Bing actually downloaded that data and integrated it into search. So that for a whole bunch of hospitals, if you type in New York Presbyterian Hospital, it pulls up in the primary search result the patient satisfaction with that hospital versus state average. By that simple act, they probably 20x'd the use of our Compare data, because you don't even have to know that Compare exists in order to actually benefit from it. I actually recently used this to pick the hospital where my wife will deliver our second child, because we narrowed it down to a few hospitals, and then for the heck of it, I went to Bing, I typed in the names of the hospitals, and one, it turns out, has a much higher patient satisfaction rate than the other. I said, you know what? That's what I'm actually going to do. There's a really interesting company called iTriage that has a iPhone, Android web app that helps you find docs, help you research medical treatments. They actually took our directory of federally qualified health centers. These are community clinics across the country that provide free and low-cost care. And they integrated into iTriage, so you can actually find them via iTriage. And in the first 3 months, they reported tens of thousands of searches for community health centers, free and low-cost care through iTriage. Another example, there was a really cool company called Healthy Communities Institute / Trilogy that partnered with the National Association of Counties and came up with a really cool software and knowledge service offering called Network of Care for Healthy Communities that for very little money could set up for any community across the country, any county health department, any mayor, a site, a public website that shows you how you're doing as a community on key health indicators like smoking, obesity, children with health insurance, immunizations, et cetera, that actually also has even more coolly an inventory continually updated of really cool things that other communities are doing to help move the needle forward on smoking cessation. Has a directory of local resources you can access as an individual or a family to help you with smoking, diabetes, healthy weight, et cetera. Very, very cool stuff. There's a startup called MiU Health in Boston that built a game called Community Clash. You can play at communityclash.com. They built it in like 2 weeks. And it's healthcare blackjack, basically. So you pick a city like Boston, you pick an opposing city like New York, you're dealt 5 cards face down, each of which corresponds to a health indicator like smoking or obesity. You're supposed to substitute up to 2 cards out for other indicators where you think Boston will beat New York, and then you show your cards. And it sounds silly, but at the expo after the main presentations where anyone could sample any of the apps, the longest line by far, was for this game. I played it for hours that night. It is strangely addictive. And I'll tell you something. So y'all know Farmville, right, hopefully? Yeah. So Farmville, of course, is the game on Facebook where you manage a farm and trade sheep with each other, right? So anybody know how many monthly recurring users Farmville acquired in its first 18 months? 18 months? 73 million. 73 million monthly recurring users in 18 months. So I'll submit to you that the person who invents Healthville and gets 73 million people in 18 months playing a game that's addictive and fun, and it happens to teach you how to be healthier, will be the most important public health figure of the 21st century. Why? Because they will do more to educate people and help spur healthy behavior than all of the mama says you should eat your spinach programs in the world combined, which is not hard because those programs, frankly, haven't done very much. And there's a very exciting new wave of companies that are actually doing exactly that. I just saw one yesterday that, well, I won't spoil the surprise because, well, I'll talk about it in a second. But anyway, this is very, very exciting. I think health gaming and social networking is a very interesting field because I think that the whole notion of browbeating them to be healthier ain't going to work, right? And the way to actually help people get healthier is to leverage stuff they like to do, like social networking and gaming. And speaking as an ex-online role-playing game addict when I was a teenager, they're very sticky, and they're very compelling. And if you can somehow jujitsu that into being a health improvement vehicle, that will be huge progress. And then the final example, I can't talk through all the apps, but final example, just to kind of illustrate different points on the map. Have you heard of Asthmapolis? There's this guy named David Van Sickle in Madison, Wisconsin, who built this himself. He basically attached a GPS device to an asthma inhaler and integrated it with a web app. So every time you use the inhaler, it records when and where your attack happened. So it shows you a personalized map and time series of asthma incidents. There's a study that's about to come out in Asthmapolis that shows that in the target population, it increased levels of asthma control, having your asthma under control, by 50%. Because you suddenly start to realize that all your attacks are happening at work or when you take a walk by the river in the morning, right? And you can take action accordingly. They're also now working on how to safely anonymize this data so that other asthmatics can actually see where to go and not to go and when. And so public health officials and mayors can say, that's a problem. There's a bunch of really weird stuff happening there. We better actually look into that because that's creating issues for our city. And the best thing about everything I just said is that the government didn't do crap. All the government did was publish a bunch of data and publicize it. Didn't issue an RFP, didn't pay anybody, right? Just actually marketed the data to innovators who actually turned around and did incredible things with it at a speed that government can't even say hello in the same time period, right? So my colleague Anish Chopra, the US CTO, had the best line at this June 2nd Lollapalooza last year. He said, imagine if the federal government had issued an RFP for any of these apps. We'd be at like stage 1x503 of saying hello, as opposed to 20 plus apps built, running public, and benefiting the American people. So we think our role, frankly, is to be a data sugar daddy, right? Our role is to take data that taxpayers already paid for, make it machine readable, accessible, publish it for innovators of the world to take, and have those innovators then turn it into amazing stuff. So we're actually now expanding the scope of the data that's been published to a whole bunch of additional data. I don't know how deeply you want to get into this. I'll just do a really quick flyby. We published a new health indicators warehouse, which has over 1,170 indicators of national, state, regional, county level health and healthcare performance, as well as drivers of health performance. We've published APIs to hospital quality data, nursing home quality data, home health quality data, dialysis data. We're going to be launching physician quality data efforts soon. Blue Button we've actually talked about. Over 200,000 unique users have downloaded their own data thus far. We're enhancing that data significantly. Department of Defense has actually just Blue Button their data for active duty military independence. Healthcare.gov, I mentioned this massive repository of insurance pricing and product information. We're going to make that available to everyone via API in 2011. The National Library of Medicine has actually been doing this for quite some time. They've just deployed an API portal that has APIs to every clinical trial in the world, massive databases of genetic information, chemical information, scientific information of all kinds. They have this super cool new service called Medline Plus Connect, which has, Medline Plus is this website that 150 million people visit a year that is a super comprehensive inventory of medical knowledge and health knowledge. And they've built this service that allows any personal health record or electronic health record app to send what medications or diagnoses a patient has and then have turn back packages of patient education information about that topic that can be for free embedded in the workflow of personal health record or electronic health record, so on and so forth. We've taken FDA recall data for drugs, devices, and food and made it downloadable in XML format. We're publishing tons of data on government spending from the individual claim level to much, much broader levels and levels in between. And kind of long story short, if it's not illegal for us to publish, we're going to publish it for free in machine readable form, downloadable. And we've published a ton of it already. And in fact, we're now actually making the mandatory requirement for every agency within HHS to twice a year present to a data council what data it has, what data it's made public, and what data it plans to make public in the next 6 months. And to make it easy to find all of it, because it's hard to keep all those websites in your head, we launched a site called healthdata.gov in February, which has a catalog of all of it, and which gets more and more data all the time. It also connects to an apps expo that shows you really cool examples of what people have done with the data already. And it has a forum where you can complain about the data, ask questions about the data, request new data, talk about what you're doing with the data, and also links to other data sites beyond healthdata.gov where non-federal data is available for free without intellectual property constraint. But it's a one-stop shop for anyone who's interested in health data. Georgie?
Yeah, so you talked about reaching out to entrepreneurs.
Oh, yes.
Are there ways of reaching out to students?
Yes, yes. That's why I'm here. But let me go into that. So actually, so all of that is about 5% of the work. Publishing the data is about 5% of the work. 95%, it turns out, is actually making people realize the data is there. So we are marketing we're marketing the data through a whole set of programs. So one is something called the Health 2.0 Developer Challenge, which anyone, including students, can enter. In fact, students, I think, are disproportionately advantaged in terms of this challenge for a bunch of different reasons. But if you go to the website health2challenge.org, it's a site where any government agency, foundation, company, or individual can issue a public challenge, a public competition for who can build the best app that does X. 21 challenges have been issued thus far. The latest was issued by the Institute of Medicine and the National Academy of Engineering. It's called Go Viral for Health. And it's a collegiate challenge where schools of health and schools of engineering or information are supposed to team up and compete to build applications that leverage health data plus social media to help raise awareness about a key health issue in your community where your school resides and help mobilize action against it. So that's actually a very exciting challenge, but there's more all the time. Anyone can enter, and the prizes vary, but it's actually attracted a ton of very talented people to build stuff. That's really cool. Codathon, so you all know what a codathon is, right? Yes? No? Have you seen Social Network? Remember the scene where there's a bunch of people in a room and they're drinking and coding, right? And they're competing to see who will be the next Facebook employee? That's a codathon. So we're doing that without the drinking. And it's actually a ton of fun even without the drinking. And what happens is basically Georgetown University or Google or HealthTap, which is a startup, says at 9:30 a.m. on a Saturday, anyone's interested in building health apps and working with health data, show up at the Switzer building and we'll scrub in on a bunch of health data and break them into teams and compete so you can build the best app with a prize at the end of the day for the best one. So you all actually should do this if you haven't tried it. It might be a great way to actually get interest sparked in your new, incredibly exciting health informatics program. And one of the things that's interesting is that actually we find that the health students, the info/engineering students don't even necessarily know where each other are located on the campus, let alone know their compatriots to work together. But at the intersection of those two disciplines is magic, right? Is absolute magic. Yes, sir.
When you say health data.gov,
Yeah.
You're not limited to data from health, from the government
Nope.
agencies. So I'd like to know specifically
Yeah.
with regard to drugs that you mentioned, if you use the data from worst pills, best pills, from Sydney World Health Research Group.
So we, as the government, are only publishing the data that we have on healthdata.gov. We don't have the ability to publish private sector data because we don't control it. Yeah, but I mean, you as a developer, I mean, it's a free country. I mean, you can go. I'm not. Do they make data available for free? They do. Great. Well, see, there's another section on healthdata.gov, which we had to go through a long process to get approved, where we actually finally got permission to list for the ecosystem other data sources that are not us. But the issue is the data has to be available for free in machine-readable form without intellectual property constraint. So as long as that's cool, then we're happy to list it. So I'd love to follow up with you about that. And just as an example of how codathons work, I went to the most recent one at Georgetown University, and it was fantastic. I mean, Georgetown isn't exactly Silicon Valley, but 130 people showed up, including a team of 5 people from Pittsburgh who got inspired and got in a van at O'Dark 100 and drove to Georgetown. God knows why. But they had this brilliant idea. Do you know what a food desert is? Have you heard about this term, food desert? So huge swaths of American cities where you can't get access to healthy food. So they came up with this incredibly simple idea, incredibly awesome, called Food Oasis, right? And it's basically text messaging meets Groupon meets a farmer's market, where they're crowdsourcing the long tail of demand for healthy food in the food desert, and saying, and so basically I can text, I want a zucchini a week, right? And someone says, I want 10 zucchinis a week. Someone says, I want 5 zucchinis a week. It all gets aggregated on a site, and then farmers can essentially respond to the demand and essentially say, I'm going to fulfill demand in this zip code for 100 zucchinis and show up every Saturday at 7-Eleven at 3 p.m., right? So they built this app in 8 hours. Louisville, Kentucky has a nonprofit farmers collaborative that's going to now prototype it. A major foundation here in Michigan is actually in the early stages of investigating to see if it could actually prototype it here and in Mississippi and a couple other states as well. And investors are beginning to be interested in it. And it's this amazing kind of snowball effect. It's really kind of remarkable. We're doing health data camps. Essentially, we're going to people's conferences and actually doing deep dive sessions about health data, educate people about it. We're doing something called the Startup America DC to VC tour. Startup America is the Obama administration's campaign to help celebrate and spur and catalyze and encourage entrepreneurship. As part of that, we're doing something called DC to VC, where Anish Chopra and I are going to innovation centers across the country and saying what I'm saying to you, which is that there's never been a better time to be a healthcare innovator, and here's why. And here are resources that can actually help you, like healthdata.gov. We actually are making a special effort to reach out to universities. So I've been to Stanford, been to Harvard, been to Wharton. I'm even more excited to be here, and going to Syracuse and other places. And so if there are friends you have in other places that would like to hear about this, I'd love to go. And then June 9th of this year, we're doing our second annual Health Data Initiative Forum, our second annual Health Data Palooza, keynoted by Secretary Sebelius and other folks. We're going to give an overview of what I just said, but 98% of the day is going to be 40 different organizations and companies presenting concrete products and services that leverage in part our data to help consumers improve their health, help care delivery get better, help communities improve their health. And one criterion for exhibiting and talking is that you have to have a sustainable business model. We're not interested in concept cars that have no prayer of ever reaching anybody. We're interested in things that will actually be sustainable and can actually help people. But we had 40 spots, and it's still early. We're only a year into this, but we had 77 companies apply, which is pretty amazing. And they're all pretty awesome, so I don't know what we're going to do. But it's a very exciting place to learn more about what's going on, be inspired, and plot what to do next. And I think actually Aman Bandari and our team is working with folks here to potentially do a virtual webcast of this meeting here. We also actually are inviting y'all to come there as well. It's actually going to be in DC, in Bethesda, Maryland, so it's open invite. And there's actually a link online. If you search for Health Data Initiative Forum, it's being held by the Institute of Medicine. You'll be able to find it and register. And the goal, actually, of this whole Health Data Initiative is for the government not to be in control of it. In fact, we want to lose control as fast as we possibly can. The goal is for it to actually result in a self-propelled grassroots health data ecosystem of health data supply and health data use, which self-reinforces and creates a lot of value for the American people. And actually, I think I'm happy to say the government's already completely lost control and been relegated to the position of data sugar daddy. And the exact moment when that happened was South by Southwest. Have you been to South by Southwest? I highly recommend going if you haven't gone. My first time going. I'm not talking about the music festival. I'm talking about the interactive festival. And I went there to go basically give this presentation. And I met with 10 companies that not only didn't need the presentation, but had already used our health data to build incredibly cool stuff to help providers and consumers who will be probably exhibiting on June 9th. I said, and I hadn't even heard of them before. I said, wow, that's pretty awesome. And among other things, actually, we announced Rock Health. You heard about Rock Health? Go to rockhealth.com. I think it's .com. It's a new incubator seed accelerator for health apps. And they are actually now taking applications for their first 6 investments. And they're a seed investor in health apps. And they're offering healthdata.gov as a resource, among other things. But they've actually built a network that includes venture capitalists who are funding them, as well as actually being the funders of the next stage of successful investments that Rock Health makes. And B, they're working with people like Mayo Clinic and University of California, San Francisco, and the Cincinnati Children's Hospital to provide clinical trial test beds for the new apps. Because one of the barriers to building cool new health apps is you've got to try them potentially in a clinical setting, but who are you convinced to do that? Unless your uncle happens to be a doctor. It's pretty difficult to do that. But Mayo's saying, we'll do that, right? And what better place could you imagine than that? So that's very, very exciting. So if you're interested in actually potentially doing your own startup, go to rockhealth.com. And they're actually one of several incubators that are in formation as we speak on the health front, which is exciting. Yeah, so I mean, there's just a kind of a growing number of new products, services, features, companies, incubators, et cetera. And I think that this new University of Michigan health informatics program, that's the first one focused on consumer health informatics, is going to be a big breakthrough. I'm so excited about it. I just learned about that earlier today. I'm hoping that if it's possible that y'all can announce it here, because like a whole bunch of people that will be incredibly excited about will be there. It's a very high-profile event. And as I was saying, I think the only problem you're going to have is that demand for the spots is going to be massive, and demand for your students who graduate is going to be even more massive. But that goes in the category of good problems to have. But one final point, actually, one interesting learning for me, which I think is actually very, very potentially interesting for you as well as students of information, is that another one of Tim O'Reilly's laws is it's a principle that I've dubbed platform jujitsu. So I talk about the Health Data Initiative as being data jujitsu. So take all this data we've already paid for, that taxpayers have already paid for, and get massively more social return by publishing it so other people can do cool stuff with it. So Tim is a similar principle that I've dubbed platform jujitsu. This is the fact that basically, similarly, lots of other people have spent billions of dollars building platforms and accumulating huge audiences for those platforms, right? So as opposed to sort of saying, look, people should just build stuff from the ground up with this stuff, with this data, which you can do and should do, that if the data is also able to infect, in a good way, these platforms, right, that it can have huge impact in a very short period of time. And that's actually something we're seeing happen, and we'll have a lot more to talk about that on that front on June 9th. So basically, kind of long story short, hopefully, if I haven't gone overly, healthcare geeky on you, a takeaway for you is that there has never been a better time to be an innovator in healthcare, particularly at the intersection of data, IT, and health, and right now, because incentives are finally focusing on improvement of health and quality as opposed to just volume of services, and because at multiple levels, at a head-spinning velocity, information is being liberated to feed those innovations that can actually improve health and quality. And that collectively comprises an incredibly rich set of circumstances, incredibly fertile soil, rocket fuel for innovation. I actually think the next 5 to 10 years is going to be the most productive and innovative in the history of healthcare when it comes to actually positive change in the healthcare system that improves health. It's interesting because I think the change in a lot of ways, even fundamental change, is actually often nonlinear. And what I'm already seeing, this is just based on empirical experience in terms of people I'm talking to and what they're already doing. The seeds are already being laid. I think that healthcare in the next 5 to 10 years is going to change for the better with a speed and a ferocity that are going to stun people. And it's actually simply because of this. And there's so many people out there who are ready to rumble if given the chance, and this is the chance of a lifetime. So I hope that there's at least one person in this room who's going to do that, because at the end of the day, the only thing I really learned as a private sector entrepreneur, that's a replicable lesson from company to company, is that if you get the best people, you win. And if you don't, it's a hell of a lot harder, right? Famously, no business plan, I can testify from personal experience, no business plan, it is true, no business plan survives its first 17 seconds of contact with reality, right? And the test is whether you can iterate your business plan to understand what your customer really wants and build it in the right way. And that is purely a function of whether you have the best team or not. Because the best teams will iterate the best, execute the best, build the best, sell the best, market the best. The same thing is true of ecosystems. If healthcare succeeds in attracting the best people on the planet, we will transform it. And if it does not, it will be a lot harder. So the reason why I'm here is on behalf of HHS and America, I am trying to pitch you on getting interested in healthcare and health improvement, because if you do, then we will change the system as a country. And if you don't, it's going to be a lot harder. So I hope at least one or two of you are interested or intrigued. And if you want to ask any follow-up questions, feel free to contact me at my email address, which is todd.park@hhs.gov, todd.park @hhs.gov. And people think I'm nuts for giving out my email address, but I do everywhere I talk. And I try to respond to everybody. If I don't, my request is that you actually follow up and say, "You idiot," in capital letters. Please respond. And that needs to be a sort by "you idiot" in Outlook and answer. So, and it worked actually. It's actually starting to work. And not to say that I haven't responded, to everybody, just a couple exceptions who called me you idiot, and I did respond. So, but I will not be offended. I'll only be offended if you don't do it, and then some vital connection doesn't happen. Because what I'm haunted by is that there's a connection I could have made. There's someone I could have talked to who's, the Mark Zuckerberg of healthcare, right? And history would be different if somehow I had just managed to spend a little more time with that person. And so I'm just, just because change is not linear, I'm just trying to do everything I can to avoid the nightmare of not having helped launch Mark Zuckerberg for healthcare, because that's fundamentally what's going to help change our healthcare system. So that's really all I was coming here to say. Is that cool? Was this what you wanted me to talk about? Hopefully? Okay. So maybe I'll open it up for questions, if there are questions. Was this reasonably clear? Was anything I said? Okay. Was there anything I said that was just, I'm a little sleep deprived? I mean, was there anything I said that wasn't clear, or was like sort of pitched at kind of an overly healthcare geeky level, didn't kind of resonate? Anything that kind of seemed sort of not totally clear?
Kind of elaborate a little bit on the platform jiu-jitsu. Was just.
Yeah. So great example is, and I'm all in favor of people building brand new platforms as well. I'm just in favor of also existing platforms leveraging our data. So as a concrete example of that, Bing, right? Microsoft's already built Bing. It's already marketed Bing. Lots of people already use Bing. Not as many as Microsoft would like, but a lot of people use Bing, right? So, the notion of actually having our data infect Bing, so users of Bing can get hospital patient satisfaction information, excites me tremendously, because that means that, people are getting that information, right, much more rapidly than if the government tried to build its own Bing, right, or other people had to build Bing from the ground up before you were able to get the information from people, right? So that's an example of platform jiu-jitsu, like leveraging not just the data the government's actually already accumulated and saying, okay, now let's put in the private sector, right, but taking all these private sector platforms, right, and having them adopt the data, if it's an interest to do it, which it is in a lot of cases, and presenting it to their audiences, right? That means that the net present value produced by the data is a lot higher than if you were depending on only brand new companies to accumulate at great expense over a long period of time the audiences that could benefit from the data. Does that make sense? So another example is there's a company called Esri, which I just learned about. And Esri is this geographic information company. It's kind of, they hate it when you say this, but it's kind of like Google Earth on steroids. They hate it when you say that, but anyway, I call it that. Google Earth on steroids, and it turns out that all 50 states' public health departments use Esri. A large number of health systems, hospital systems use Esri. A whole bunch of health insurance companies use Esri. A whole bunch of government agencies use Esri, right? And they're taking a bunch of our data and integrating it for free into their mapping platform, which will then instantly benefit all their users. And so I'm supposed to go to this Esri Palooza in July, where like 15,000 maniacal Esri users, a lot of whom are interested in health, to get them excited about health data, And so that's what I mean by platform, right? It's not just a technical platform, it's a whole ecosystem of users of the platform that can then turn that data into benefit very, very quickly. So that's what I mean by platform jiu-jitsu. Wow, okay. Let's work front to back, I guess. So, yes?
All right, so the information liberation is a wonderful, wonderful trend. But if I look at my own situation, my clinical care provider's got like a couple BP readings, a cholesterol test, height and weight annually. I've got, over the past year, say 300 nights of EEG data, looking at my sleep. 360 days of actigraphy data, genotyping information, composed of a few million SNPs. Is there any role HHS is playing in also creating information appetite for the healthcare system to be able to federate with data collected from consumer devices and actually incorporate that into patient care?
Absolutely. And it's actually, in general, and this might, it's an interesting statement to make. We're trying to figure out where we have an essential role and only doing that. So if the private sector can do it, our attitude is the private sector should do that, right? So I think our play there is as opposed to sort of doing kind of this top-down, thou shalt federate data, et cetera, right? We think actually the root problem is incentives. So I would submit to you that health information exchange in healthcare has not been a technology problem. It's been an incentive problem. There have been active disincentives to share. So, but if you're in a universe, right, where, frankly, healthcare providers, right, are now rewarded for care coordination, for keeping you healthy, right? One of the first things that they are now thinking is that they need to engage with the consumer. They need to actually engage with the home in a far deeper way than they ever have. You know, so famously, I'm sure you know this, but 75% of healthcare spending in America is on chronic disease, right? And if you know how to manage chronic disease, right, it is not about what happens in the doc's office at all. It's about what the patient chooses to do at home. It's what the patient chooses to do everywhere but the doctor's office, basically. And so, you know, you're seeing these new provider systems, these accountable care organizations, et cetera, start to go to these consumer tech conferences. And they're like, you know, fish out of water. You know, they say, whoa, what the heck is this? And I was at a consumer tech conference recently, and I saw the SVP of this major Texas health system. I said, what the hell are you doing here? He said, well, I'm going to turn myself into a accountable care organization. And I've thought about it for like 18 seconds, and I've realized I have to be able to engage the consumer. So I'm here to give these guys a business case. And that's what's been missing is the business case. I mean, all the sensors, the technology, all that stuff. I mean, other industries have just done that already. It's like a totally solved problem, right? The innovation requires the business case. So we're trying to help create the business case. Starting with Medicare, right? But as I mentioned, like Aetna, Blue Cross, et cetera, they're all going to copy Medicare. They've all been wondering why it's taken us so long to do this to begin with. That's a good question, but we're finally doing it. The government's finally doing it, yeah.
You know, I'm thinking about these, I think from the point of view of the 2011 meaningful use requirement of data capture and sharing.
Yeah.
This is a big step in the right direction.
It is, yeah.
I'm just wondering what you're thinking about in 2013 and 2015 when
Yeah.
we have to go to advanced clinical processes and improved outcomes.
Yeah, yeah.
What kind of technological innovations do you see there, and what kind of communities of practice and services would we like to build to enhance that capability?
Yeah, yeah.
ACOs and other things.
Well, there's a really kind of intense open public process that's going to be launched to help govern that, right? And so, and that will ultimately determine what it is. But I mean, a lot of it's about enhanced clinical decision support, right? You know, what stitching time saves 9, enhanced exchange requirements, and ultimately 2015 is about improvement in actual outcomes. And that will actually meld very nicely with the payment reform that Medicare is doing and other insurers are doing to help reward you for improved outcomes. So it'll all kind of self-reinforce. But kind of in a nutshell, I think it's all about if you're a doc, right, or a nurse, really being able to get a comprehensive picture of a patient's health and the care that's been delivered to a patient, being able to run that against a rules engine that tells you what gaps in care this patient has, and then be able to reach out and touch the patient to bring him in for that care. Because that's really, frankly, at the end of the day, what's going to drive a lot of improvement. So the single best health economics paper ever written, in my opinion, and I'm not being hyperbolic, was written by Elizabeth McGlynn at Rand Institute in 2003, I want to say. What she did was she identified basically every major zone of American medical care in 3 categories, acute care, chronic care, and preventive care, and said, what are like the 1, 2, or 3 things that every fourth-year medical student knows you always do 100% of the time in each of these situations? And then she went and had her students do an audit or fellows do an audit of 15,000 medical charts to see what percent of the time these things actually happen. Anyone want to guess what percent of the time the most basic things actually happen? 50. Yeah. So half the time, the most basic things that any fourth-year med student could have told you to always do didn't happen. Now, clearly, it wasn't because the doctors didn't know to do that, right? It's because you didn't have a comprehensive picture of all the care. There was no rules engine monitoring that picture to say this didn't happen. There was no follow-up mechanism to ensure the gap got closed. So actually, the British recently announced a major innovation that has revolutionized healthcare in a particular situation, right? That has like dramatically lowered cost and improved quality and health. It's called a nurse. They put a nurse in a medical office who read through all the charts, found the gaps, and just pestered people, docs and nurses, followed up with patients until the gaps got closed. It's just about it's a process control, right? I mean, medical offices and hospitals, I mean, we practice in a 19th century way. There's no process control. The only reason our healthcare system actually is any good is because we have the best doctors in the world by far. But they're laboring in a system that's pre-industrial. It's 19th century. The good news is that actually, if you do an even modicum of process control leveraged by IT, right, you can experience dramatic changes in cost and quality in a very short period of time. You can actually do the stitches in time that save 9, that keep people out of the ER, keep people out of the hospital, and stay healthy, which is both better quality and lower cost. It's very basic. The flip side of healthcare system being so screwed up is that it's actually not that hard to fix it if you begin to create the conditions to support fixing it. So we're going, you're welcome. So front to back, who was next? There were folks here. Jessica.
So I'm hearing about all this data. I'm thinking
Yeah.
patient health information,
Yep.
which is protected by HIPAA, federal statutes.
Yep.
Providers also have certain duties they owe to patients, including privacy.
Yep.
So how do you reconcile trying to make all this transparent and gathering all of this data and still respecting the patient's right to privacy and not freaking out providers and being, oh, and by the way, you're going to be subject to liability and litigation?
Yeah.
Because that's certainly a big concern for healthcare providers.
Yeah. No, patients' right to privacy is paramount. Non-negotiable, absolutely paramount. Nothing will be done, nothing can be done, nothing should be done to violate. In fact, we're interested in actively safeguarding it further than it is today. And so we're doing a lot of work on that. The data we're publishing at healthdata.gov is not personal data. It's like FDA recall data. It's like insurance pricing data. It's hospital quality data. It actually, all the data sets that get published have to go through a rigorous test to ensure that they don't fail the mosaic test, which is not just sufficient for it to be de-identified. It actually has to be so de-identified that it cannot be linked with other data on the web, including future data, to re-identify Grandma Jones and her history of depression, right? So we're steering incredibly clear of that. Now, Blue Button is different, right? That's basically you get an account on mymedicare.gov, which is a web portal. You authenticate yourself. You can already see your own information. We're just allowing you to carry a copy of it away. That's it. And the fundamental principle around patient data mobility is that, which we've articulated, is data needs to go wherever a patient needs for it to go. That is actually not true today. Try asking your local hospital system for a copy of your own data. Good luck. What's that? Which is ridiculous. It's your data. It is your data, right? And it could save your life. Here's the thing, right? So a big part of what we are promulgating is, as part of meaningful use, and as part of the rules around health information exchange, is that data has to be able to follow the patient. It can't be bounded by a vendor's installed base. It can't be bounded by a health systems network. It has to go wherever a patient needs for it to go. It's a fundamental right. And I think providers are beginning to get that. And we're taking away the excuse that's hard to do. We're making it really easy to do. We say, like, your teenage son can program this. Right? So it's not an excuse. You can do direct and do secure healthcare email to send the information to another provider. So just do it. And it's not us asking, by the way. It's patients asking. We're just trying to be helpful. Yes?
It's a class-related question, but so I just wanted to ask you about your own job.
Yeah.
You have like a very entrepreneurial job. You have a free hand.
Yeah.
How many times do you have to face the red tape, or do you have to deal with
Yeah. Weirdly, and people don't believe me when I say this, but very little. People keep expecting me to report the 18 forms I have to fill out in triplicate to go to the bathroom, and I actually haven't filled out a single form. I filled out a form. There is a form to bring champagne into HHS headquarters. There is an actual 2-page form. And the team that built healthcare.gov for me earned the champagne, so I filled out the form and brought in the champagne. That's the only form I filled out. So it's weird. Maybe it's an aberration, but it's been incredibly, I don't want to say easy, because being an entrepreneur is never easy, but it's certainly not been more red tape than I dealt with in the private sector, And actually, the way that I roll is I didn't do any of this. What I did was identified a cool idea, then I found the 3 to 5 people at HHS who knew a lot more about it than me, who've been obsessing about the idea for years, who had data and resources and connections, and I put them into what I call a virtual startup and said, I will be your sponsor, right? I will give you the air cover to do this. I'll be your virtual CEO. And then they did it. They built healthcare.gov. They actually are executing the Health Day Initiative. They're actually doing a whole bunch of this really cool stuff. And so I'm really uncorking champagne, metaphorically. And these guys know how government works. They know how to get stuff done. And it's actually really, really helpful as well to be working closely with the Secretary and Deputy Secretary of HHS. So think of it as the CEO and President of HHS, and with the White House, the Board of Directors. Because when those folks support you, it's a lot easier to get stuff done. But it's been very, it's moved incredibly rapidly. Like one story, so this whole idea of the Health Day Initiative, I mean, this is a true story. I drew it on a single PowerPoint slide that was very primitive looking, where I was showing like the whole ecosystem, right? I said, look, as opposed to us building like a map, right, that shows how to use this data and us building all the apps that use this data, why don't we just publish all of it? So I drew kind of a map of what the ecosystem would look like. I met with Secretary Sebelius for 15 minutes. At the end of 15 minutes, she said, do it. I love it. I said, well, isn't there like a steering committee I'm supposed to go to? She said, you just talk to the steering committee. Just go do it. And so I went and found a team of people to go do it, right? And as opposed to sort of, the bureaucrats being troglodytes, which so many people think, totally not true, actually. I went to Medicare, Medicaid, right? Which has a reputation for being this opaque bureaucracy. I remember sitting down with the career civil servants that at the time were running the place. And I had this whole elaborate pitch about how it was important for them to liberate their data because it was so valuable. And I privately projected 7 months of argumentation to get them to the place where they would free their data. And Charlene Frizera and Michelle Snyder, the career civil servants running the place, said, okay. At the end of the meeting, they said, fine, let's do it. I love it. I said, well, aren't you supposed to argue? And they said, actually, they'd been thinking about this for 1.5 years already. And they'd come to the conclusion that in 5 years, data and information products, their phrase, from Medicare would be regarded as important a service as Medicare itself. They said just nobody in leadership ever made it a priority. Nobody ever provided them with the air cover to do what they knew needed to be done. And all they needed was air cover. So I highly encourage people to spend a stint in public service. Because A, you'll serve your country in ways you can't possibly imagine. B, you learn things about your government that will surprise you. Like my whole conception of government is radically different than before I joined HHS. I have so much more faith in my government than I did before. Not that I was a skeptic before, but it was just an unknown quantity. There are so many motivated, idealistic, mission-oriented. They're not there for the money, trust me. They're there because they believe. And I may be working disproportionately with the ones that are exceptionally mission-oriented and exceptionally entrepreneurial, but there are a ton of them. They did all this. I feel pretty strongly about this. Sorry, I didn't mean to go on a... What's that?
A lot more candidates to reach with the message.
Yes, that's true. This is true. Okay. Yes, sir.
I'd like to go back to the patient access question for just a minute.
Yes.
Blue Button works great, and I should say I'm in that business of patient access platforms. And
God bless you.
Crazy, and we run into exactly that problem. When we present it to a population where we have a health information exchange or a firm, a hospital provider presenting, we take care of the integration is seamless.
Yep.
When we have consumers or patient advocacy groups going back, it falls flat. Half because meaningful use stage 1 in the final rule, like the early stages, gutted the requirement to export a data file and made it one of the optional conditions. Now we look at ACO rules. Love the rules, by the way. Wonderfully written, 429 pages. But the question for you is, what can you tell me that I can tell my clients and prospects about how we can, in the near term, not wait till meaningful use stage 3 is the first place it comes up, not even in stage 2, to get access and control into the consumer's hands?
To basically get data exported into the consumer's hands?
Yes.
I would say don't wait for the government, actually. I think that there's going to be a profound and growing business case for care providers to actually do this, to help do their job as accountable care organizations and as organizations that actually start to be rewarded for actively managing population health. I think there's actually a strong case to be made that one of the arguments that care providers actually made in the past was that what's the consumer going to do with it, right? But there are more and more platforms out there that are incredibly powerful that can help consumers help manage their health, which is in the interest of these providers to support. So I would say, yes, the government will keep doing everything it possibly can to help encourage this and help move the provider community as rapidly as it can in this direction. We'll keep trying to set an example through things like Blue Button, So here's one very specific technical suggestion. One thing that you'll hear from care delivery providers is that it's very hard for them to do this, right? The magical thing about Blue Button is that we said, look, don't obsess about the format in which you're going to export the data, okay? Don't worry if it's a CCR, CCD, C32. Just whatever you can out there, just out there, right? So the CMS VA, DOD, Blue Button file is an ASCII text file. Now we're going to also do a CCR CCD, but we just start with ASCII text file. It's like 17 lines of code. It's absurd for someone to not be able to do that.
To make that readable in a slick little fashion.
There are a lot of people who are making it readable, and people doing incredible cool. Like WebMD's built a mobile app that actually essentially uploads the data and then presents the WebMD information to you that is applicable to you based on your profile, right? Adobe actually makes it look readable. HealthVault has to be able to suck it up and have it power a ton of different applications. So that's my point, is that there are a lot of companies out there that will actually turn it into useful stuff. All the care delivery provider has to do is just make it public, right? If they already have a patient portal, which they all do, just add a button that you can hit to download the info that they're already showing you in their portal. And if they say it's illegal, say, well, the VA and Medicare did it. And if they say it's really hard, they say, well, the US government did it. Are they smarter than you are? So I would just do that. I wouldn't wait for the government. I mean, we'll be supportive, and we'll move things as fast as possible, but I think that actually there's a lot you can do even before we move forward with our regulatory process. Does that make sense?
It makes sense, but the vendors of the EMR systems are blocking it.
Yeah.
That's interesting. So they
block it by saying to a provider, if a provider says, my clients are beginning to ask for this.
Yeah.
If I've gone to a soccer club and said they want to get this as a means of having their soccer information instead of immunizations 14 times through the year.
Yeah.
The vendor says, sure, for $50,000.
Pitch them on Blue Button, specifically. Here's where it's important to get specific. Say Blue Button. Because Blue Button is all about simplicity and all about doing something very, very quickly. And it does not cost $50,000 to put a Blue Button on the portal that actually spits out an ASCII file. Don't let them kind of over-complexify it. So try that. Let me know how that goes.
We might exchange emails on
That'd be great. I'm very interested with this. I'm very interested. Yeah. Let's keep going backwards. Yes.
You started your talk with some of the reforms of the Affordable Care Act. Now we're changing the way we pay for healthcare.
Yes.
And that the information that we're making more liberating will help providers understand how to provide healthcare to meet those incentives.
Yes.
I guess I'm wondering whether any of the work you're doing is helping the government figure out how to measure value. So
Yes. Yes. So there's a huge amount of work. And again, it's the government helping America measure value, right? And so I'm very sensitive about this whole idea of government being the...
I mean, if the big payment reforms are happening through Medicare, the government better be measuring that.
That's right. But it's again kind of as an agent of market transformation. So the really interesting thing to me is not just that Medicare is going to do it, but that's going to be emulated by lots of other people as well. But let me make my point more concrete. So yes, so there's a huge amount of work that the Affordable Care Act calls for around quality measurement. So for example, we're supposed to enhance the hospital quality metrics we already publish. And we publish a ton of hospital quality metrics already, which like nobody knows about, like 27 metrics around readmissions, mortality, rates at which things are happening in hospitals that aren't happening or are happening, so on and so forth. So again, kind of the onus is on us to market that so people know that there's a lot of value data already out there. And it's not perfect, but it's at least a directional beginning. So the Affordable Care Act directs us to deepen that for hospitals, but also add critically that kind of measure set for physicians through a very open public process. We'll be talking with lots of doctors and patient advocates, et cetera. Even more importantly, in my opinion, there's a section called 10332 of the Affordable Care Act, where Medicare is now allowed to give its entire Medicare claims database to any qualified public or private entity that is capable of dealing with it securely and mashing it up with other data to help measure provider quality. So that means there'll be a lot of additional smart people working on this problem besides us, which is actually really, really important. And there's a set of defined metrics that you'll be able to use this data to measure. But very importantly, any of these qualified entities can suggest additional metrics that the entire community should now be able to measure. That's helpful. So my hope is that actually the community will invent a bunch of new metrics, and so we'll be able to progress our quality and value measurement cycle. We'll be able to accelerate that much faster than if it were just the government itself doing all the R&D and funding all the R&D on quality. So there's also actually a ton of, if you go to the Health Indicators Warehouse, for example, there are over 1,170 metrics of health and healthcare performance in terms of health performance. Because it's not just about the quality of care in a doctor's office or a hospital. It's also about public health outcomes like smoking, obesity, et cetera. And there's a ton of data we have about that. And actually, one of the most interesting things that we're seeing is that these care delivery systems, like health systems that are becoming accountable care organizations, are very interested in sucking that data into their business intelligence systems, so they have situational awareness about population health, because actually they're understanding that for them to make the most money as an ACO, they have to actually potentially optimize not just what happens within the walls of their hospital, but actually understand what's happening outside the walls of the hospital. Like a food desert may actually become in scope as a problem that the care delivery system wants to attack because it impacts health. So I would say that the science of value measurement is still relatively early, but surprisingly far along, as paradoxical as that sounds, right? I mean, there's a lot of data already out there, but it hasn't fundamentally been tapped or used because no one's really given a crap, except for academics, no offense, right? Which hasn't really had a lot of impact, honestly. So the actual care delivery system, people who actually keep moving the needle directly on health and value haven't really been funded to do so, weirdly. But that's now changing. And that will then directly, I think, turbocharge use of this data and also help advance it, I think, much faster than it has in the past.
Right before I came here, I was in a health IT class.
Ah, how cool.
Super cool.
Yeah, super cool.
A physician was walking us through the EHR system like that in Michigan.
Okay.
That happened to be the one that's in place. And it really is clear that these systems, even if they're meeting the meaningful use requirements,
Yeah.
are still extremely user-unfriendly.
Yes, they are.
And so it's running the situation with the
Although actually some of the new ones, it's interesting. I mean, the one I'm sure that UMichigan is using, I'm sure it's perfectly fine. But how should I got let me see. So there are 290 systems that have now been certified for meaningful use. 60% of them are companies less than 50 people. They're startups. And they actually have not been burdened by having a technology base that was last really cool in 1985, right? So I've seen iPad-based, super intuitive EHRs that aren't yet being used by University of Michigan because they're not yet ready to be used by University of Michigan. But there's an interesting trend line there. And actually, there's anyway, I don't want to. There are really cool new entrants in this space that are very experienced in consumer user experience design in other fields. They're now bringing that to healthcare, which is, I think, incredibly important, actually for both doctors and for consumers. Yeah. And so I would, if you're interested in that, you should absolutely do that. There's a huge opportunity there, massive. What's that? Yeah. Oh. Oh, sorry.
Given the financial incentives in place
Yeah.
now for systems to put EHR in place, how are you, or how is it
Yeah.
incentivizing systems to maybe wait a little bit until these great startup companies can be, their products can be scale?
Yeah. No, we're not trying to micromanage the market at that level. I mean, I'm a big believer in just get started. For anything, whether it be start a company or help to catalyze an ecosystem, just get started. And I think if you wait for the perfect product to exist, you'll never get started. And the way to get to a perfect product is to actually get started. And so. One thing, though, to your point, that we are trying to do is right now, if you go to a doctor or you go to a hospital system and say, I think you should change your electronic health record, you might as well have walked up to a person and said, I think you need a heart transplant, right? I mean, it's like the fastest way to get fired is to suggest doing a system transformation, a system implementation. So there are a variety of things you can do, especially by making data more transportable and more liquid, right, to make system change a lot easier and thereby essentially get more dynamic flow of new systems into hospitals and doctors' offices. So there's actually a very cool group of folks at Harvard, Professors Mandel and Keohane, who got a grant from HHS to build something called the Smart Apps Platform, which essentially is an interchangeable modular electronic health record platform. It can be like an iPhone app store, but with interchange capability for data between the apps. So that you can actually, instead of buying one monolithic giant slab of software from some giant EHR company, you can buy the e-prescribing module, the lab module, the encounter documentation module, the reporting module from different people, and swap them in and out, right? Which then makes it much easier. So that I think is kind of the key, is to make the barrier to switch a lot lower, and then you'll, I think, really help to make it more a dynamic market and put more pressure on people to suck less and do a better job. So, yeah. Yes.
I want to talk a little bit more about startups. So
Yeah.
for the data you're publishing now, it's
Yeah.
really easy for me to start a startup and make that and get that going.
Yeah.
However, the really cool engineering stuff that can be done is really good with the personal medical data. And doing a startup for that type of application is much more harder because, as you pointed out, you have this huge data security aspect.
Yeah.
And it seems like if I were to try to start a startup, every other startup in this area would have the same security requirements. And starting a startup for this personal data is very different. So it almost seems like there needs to be something in place to provide startups in the healthcare arena of then to get going with this secure data in some way. Otherwise, you're only going to have the IBMs, the Googles, and the Yahoos actually building products because no one else can get into the field. How do you support these type of startups using sensitive data?
Yeah.
Allowing us to say start a company.
Actually, I don't think that handling the data is the hard part. I think that actually building a business model is the hard part. So, and what I mean by that is that actually, I think the barrier that I'm seeing with the personal health data companies is how do they aggregate enough consumers fast enough to be able to make a go of it. That being said, there are 10,000 personal health apps on the iPhone, iPad App Store. Microsoft Health Vault has like a gazillion apps that ride Health Vault, which is free to the app developer, right? There are startups like HealthTap. They're doing something very similar, giving you a platform that aggregates personal health record information, enable you as a developer in their network to build cool apps. So I think the barriers are coming down, but it doesn't take like $1 zillion of technical effort to build an app that can handle this information securely. But the challenge is actually building a customer base, and but honestly, as people build platforms and channels like the App Store, like Health Vault, like HealthTap, et cetera, I think it's becoming easier and easier to do that. Yeah. Yes, ma'am.
My final project is on health information exchange.
Wow, cool.
Actually, I interviewed one of my professors at Healthcare and Oncology Department.
Okay.
And he mentioned the aspect of accountability in the health information that's being exchanged.
Yep.
So, to concisely put it, who's ultimately responsible for the exchange?
Sorry, who's ultimately responsible for the accountable?
Information being exchanged.
In what sense of the word accountable?
If there's a medical error that happens,
Yeah.
when a provider receives the wrong information,
Yeah.
the provider, performs an operation, and the operation is actually not necessary,
Mm-hmm.
and it was due to the health information that was incorrect in the first place,
Mm-hmm.
and it was from a different institution. So,
Yeah.
who's ultimately responsible for that?
Yeah. I actually am not an expert in that particular field. There may be an answer to that that's been established by policy, but I don't know what it is. But that's a great question. There's a whole set of people who are working on that, and I should find out. That's a great question. Sorry, I don't know it. So I don't know the answer, but.
Sorry, I think at least for part of our class we have to wrap it up.
Oh, okay, great.
But I did want to, there's one little issue that our class does want to discuss a lot, so I wanted to make sure we address it. Is part of what we do is stuff on information use in communities.
Yep.
And I want to know if there's any part of your work which involves speaking with communities as a unit and getting them more involved.
Oh, absolutely. You mean like communities,
Yes.
like physical communities?
Physical communities,
Oh, sure.
of one specific healthcare requirement.
Oh, absolutely. Yeah. There are, the short answer is yes. So for example, there's a lot of work happening around measuring the health of communities. Robert Wood Johnson Foundation, University of Wisconsin have this project called County Health Rankings, where they're using a bunch of our data and other data to rank counties in every state in terms of health and drivers of health, which is causing a whole bunch of conversations to happen at the community level about how communities can improve health. Esri has a venture that they've done in Southern California called Healthy Communities by Design, where mayors are actually coming together using Esri to basically try to proactively make moves that can improve the health of their community around walkability and housing and access to food and plugging play deserts, and that kind of thing. There are communities of patients forming. Obviously, that's been true for some time, but they're intensely interested in data. So, for example, Patients Like Me is this very interesting site where people are essentially just self-publishing all their detailed data voluntarily if you've got a rare condition, because it's incredibly valuable to each other to do that. And they're interfacing with clinicaltrials.gov. And they've built a new utility called Trials for Me, where basically you can use your own data to identify on an ongoing basis whether there's a new trial that would be relevant to you in a certain geographic radius. So that's incredibly interesting. There's a whole lot of discussion about the meaning of community as well, right? And so, because I think a lot of the initial activity was around geographic communities, but they're communities by condition, communities by affinity, et cetera, right? And so, actually, some of the gaming companies are allowing you to kind of self-form little mini communities to compete against other communities, to see who can be the healthiest or do the healthiest things. So yeah, there's massive activity on that front. Yeah, absolutely. Yeah, and I think the technology and information can play a critical role in helping facilitate community-based awareness and action, however you define community, especially with the advent of social networking. So.